The regular attenders at our seminar series here are already familiar with Cary, who gave a presentation before, so I don't think we'll go into a lot of detail, but for folks who are new, I'll just briefly. We have a National Institute on Aging-funded Weill Center, which unites the clinical medical research folks on the Weill Cornell campus and social and behavioral scientists here around the area of translational research on aging, with a particular focus on how to deal with chronic pain in people. And as part of that, one of our speakers has been involved in the center greatly, and I do just want to say, and Cary himself, for those of you who don't know him, is a professor in the field of geriatrics at Weill, and does a wide range of different kinds of research, a lot of it around pain and palliative care and related issues. And we think of him as an honorary social scientist because a lot of his work is more like ours than it is about molecules or microbes or that kind of thing. He's also a practicing geriatrician. And I think with that, because you've been involved, you're going to introduce our folks here.
So Rachel Sherrow is Chief Program Officer at Citymeals-on-Wheel in New York City. For those who don't know, Citymeals provides much-needed services to roughly 20,000 frail, older New York residents, and she's doing a bunch of exciting work in a number of ways, which she'll share with you shortly. Kavita Ahluwalia is an Associate Professor of Dental Medicine at Columbia. As Carl mentioned, she works closely with our center and has for a number of years worked at the interface of oral health in the community, working with a number of agencies, and is here today to talk about the partnership that brings her expertise and efforts together along with Rachel's and Citymeals-on-Wheel. So welcome to you both.
Thank you. In case it's not obvious that this is a Rodney Better Center pilot grant.
Thank you.
So one of our pilot grantees.
Okay. Just a little background on Meals on Wheels and who City Meals is and what we do. Meals on Wheels is a federally funded program. It's been around now it's closer to 50 years. Throughout the country, there are areas on aging. So every area like Ithaca has an area on aging, and then they do things for the aging population. One of those things is Meals on Wheels. New York City, all 5 boroughs, is one area on aging. It's under the Department for the Aging. The Department for the Aging, also known as DFTA, funds the Meals on Wheels program, which go out Monday through Friday to homebound elderly, those who are assessed as being unable to shop or cook for themselves. They're assessed by case managers, who are most often social workers. They go through a rigorous assessment form. It usually takes about an hour and a half in their home, where they can speak with the client, the potential client, and look around the home and see really what is going on, and see, in addition to Meals on Wheels, what other benefits they might be eligible for. City Meals on Wheels was founded 32 years ago as a public-private partnership with the Department for the Aging to fund weekends, holidays, and times of emergency, because our co-founders couldn't believe that a homebound person wouldn't get a meal on Thanksgiving or other times of the year when the city shuts down. So now a homebound person gets a meal 365 days a year. It's the same 33 agencies throughout the 5 boroughs that deliver the meals Monday through Friday as they do on the weekends. Same deliverers, same staff. It's just a different stream of funding into those agencies. As Dr. Reid said, it's a little under 20,000 meal recipients. It's closer to 17,000 people citywide who get Meals on Wheels every day. And they run the range, it's a pretty big range of clients. It's not a benefit. It's not a federal benefit, even though it's a federal program, meaning that it's not like food stamps or Medicaid, so it's not financially based. So anybody can get it. So we'll get phone calls sometimes from New Yorkers who say, I live on Park Avenue and my neighbor gets meals, so they're stealing and they shouldn't get the food from you. But nobody knows what goes on behind closed doors, and nobody knows that maybe that person bought that apartment or is renting that apartment or bought it for $10,000 50 years ago and now has nothing else. So we're able to give people who really need the food the food. Also, it's better to get Meals on Wheels than order in from the local deli, financially and nutritionally. Also, just to mention that the Area on Aging in New York City is the largest throughout the country, and the Meals on Wheels program is just a meal. They're just getting a meal. It's a quick visit. This is a deliverer delivering the meal. They're literally giving them the food, and they leave. It's not really a social visit, although the relationships that develop can become pretty strong. A lot of deliverers stay in their job for many, many years, and they're often the ones who can tell if something has changed, if there are issues with the client, and then they report back to case management. They also sometimes find them on the floor and call the police in that instance.
So, Rachel, do you want to just talk us about how you get meals?
The eligibility for Meals on Wheels, as I said, you have to have a reason that you can't shop or cook for yourself. There has to be some sort of handicap involved, whether it's the inability to hold, to stand over a stove for a certain period of time, to open cans or other kinds of food in order to cook for yourself, or maybe you can go down to the supermarket and get a loaf of bread or maybe a quart of milk, but you certainly can't buy groceries, or you're financially unable to buy food. And then there's the other spectrum of people who are really homebound, who live on, in walk-ups in New York City. There's no elevators, and they're literally prisoners of their own homes, and they can't get out. And this meal is obviously one of the meals, is the only meal that they get from our system a day, and it's a third the RDA dietary allowance. So we're hoping that they're getting those other two pieces. Oftentimes they're not. And City Meals actually has a very small program, a mobile meal pantry program, where we're bringing pantry bag items into the clients' homes who are the most in need, the most food insecure, which is just another nice way of saying hungry, since they can't wait on pantry lines, obviously, and lug that kind of food home. So we know that for many of our clients, one meal is not enough a day.
So I just wanted to say, if you have questions or comments throughout, please feel free to interrupt. I think it just it's more useful that way. This work, the work that I'm going to describe now, the pilot, builds on Ed Frangillo's work. He was funded by, I think, a predecessor to the Bronfenbrenner Center called BLCC, as well as the Roy Ball Center. So this just kind of shows you some progression. So switching from Meals on Wheels to teeth, we have a lot more teeth in older adults now, mostly because of fluoride and better prevention at younger ages, where you're finding that now people are retaining teeth. So in the 50s and 60s, it wasn't unusual to have a very large proportion of older adults with no teeth, and actually to have young people with no teeth, 30s and 40s. Now we're finding that just about 27% of people over the age of 65 have no teeth at all. So this should be a good thing from a dental point of view. We're saving teeth, but what it's really resulting in is more disease. Now you have teeth, so you have dental caries, you have gum disease, and you often find mouths that look like that. They're very...
during lunch.
Sorry. This is an edentulous person, and this is a fungus going on under the denture. So even if you don't have teeth, there's still need to access dental services. In addition to having all these extra teeth now, it's becoming more of a problem because diseases that we overwhelmingly see in older adults, especially diabetes and heart disease, are increasingly being associated with gum disease. You only have gum disease if you have teeth. So that wasn't an issue before, but now it's a growing issue. Also, if you are unable to, Rachel mentioned that there are some people who can't stand long enough over a stove. Those same people can't stand long enough over a sink to brush their teeth, or they can't hold a toothbrush. But nobody's really investigating this. Nobody's looking to see, exactly what the prevalence of this is and what can be done. And then finally, there's, a lot of medications that exacerbate oral diseases. So diabetics have dry mouth. That puts them at high risk for dental caries. If you're on a diuretic, you're going to be at high risk as well. So we're seeing a lot more dental disease, and we're also seeing a lot more impact on quality of life. You need your teeth to be able to eat, which is what this project's about, but also to speak and to kiss and everything else. The way you look. My father lost his teeth about 10 years ago, and then just didn't, have the means to kind of have himself remade. And about 2 years ago, he got himself remade, and it looks like he's 10 years younger because, his face is not collapsed anymore, and he's back to being where he should be. I can't tell you how many times I go into homes and, people, it's a concern for older people. They'll be wearing a denture, and I'll say, you need to take this denture off at night. And the answer is, no, I will not take it off. Well, why? Because my boyfriend doesn't know that I have no teeth, and I'm not going to let him know. And I'm thinking, yeah, I'm sure he knows. So it's important. It's very important. Of course, pain is an issue when you have teeth. If you're going to have dental caries, you're going to have gum disease, you are going to have pain if it's not going to be treated. And that picture I showed you of the palate with candida, that's very painful as well. So despite all this, access to care is very poor. Poor older adults are less likely to have dental insurance. This is a very old slide from 1995. At that time, only 7% of poor older adults had no dental insurance, and I'm pretty sure, given today's economics, that it's much, much higher. I'm sorry I don't have more recent data. But Rachel and I were in the car talking, and the dean of the dental school always says to me, but if you're not poor, you can go to the dentist. Why is it? Because I'm always talking to him about poverty and access to care and how difficult it is. And he's always saying to me, but there's a whole proportion of older adults who are, quote, not poor. But they're all on fixed incomes. They don't have private insurance, and Medicaid does not pay in most states. In New York, it does pay for adult dental care, but it's not comprehensive. So in New York, if you have a denture and it breaks, you can't get a new one for 6 years, which means that if you're getting a meal from them and you don't have a denture because it broke, you can't eat it. And Medicare has no dental services at all. So, all this to tell you why we chose to focus on the teeth. Well, partly because I'm a dentist, and so I like teeth, and that's, but also because teeth are central to your ability to eat, and therefore also central to the mission of Meals on Wheels. We also are doing a study through Triple, and this study is indicating that close to 40% of the meal recipients say that they can't eat because of problems with their mouth, teeth, or dentures. And we think we can do something about this. So I showed you that access is really poor, but the morbidity associated with dental diseases can be arrested with good daily oral care. So we think that, there is something that we can try to do. And then finally, we felt strongly that since access is so difficult, if we try to embed some interventions in existing systems of care, that might help us move ahead. So these are the study aims for the pilot study. We wanted to convene a community advisory board and then use the advisory board's expertise and relationships to understand the systems of Meals on Wheels and case management and understand what the challenges are and where we can embed interventions. And then we wanted to develop some interventions and bring them out to the advisory board and ask them to kind of prioritize for us what they thought would be the best way to tackle the problem. think we spoke about this, but the partners are Citymeals-on-Wheel, Columbia, and Weill Cornell, and of course Cornell now through the Bronfenbrenner funding. So we used a CBPR model. We have a community advisory board made up of 7 individuals, and Rachel was key to kind of helping us put the advisory board together. Do you want to talk a little bit about why you chose the people you chose?
Sure. We wanted a spectrum, a range in communities in New York City, because although New York City is one city, every neighborhood, every community is very different, and the agencies that work within their communities really know their communities and their people very well. So we wanted to pick people from different areas. We have somebody from Queens, Brooklyn, the Bronx, and Lower Manhattan. And we also chose people, some Meals on Wheels providers and some case management agency people, and those who were really the best in their field, some of the best, so that we knew we could really access a lot of information from them, and if we needed to, talk to their staff and other people, they would be very helpful for us, and it's been very helpful.
It has. We meet with them almost once every 4 weeks, and then sometimes more often, sometimes a little bit more spaced out depending on what's going on, holidays and so on. But they have really, for me, I was sort of walking into this not really knowing what Meals on Wheels is about, but have really helped me sort of understand the system and where the gaps are and where the challenges are. They have been incredible. They've always been there, sort of willing to think through things, talk through them, and also willing to, give up their resources and have people, sure, I'll have my person call such and such and help you set up such and such interview or talk, because in addition to working with the CAB, we did 2 focus groups, 10 people each with caseworkers, and a bunch of key informant interviews with about 8 people, and then informal interviews that happened over the telephone and so on. But they were really key in sort of helping us set up the focus groups, figuring out who I should go and speak to, and also inviting me to come to their programs and go out and deliver meals and meet with their workers, just so that I can actually understand how it works. And then we developed some potential interventions and had the advisory board sort of vet them out for us, telling us what they thought would work and what wouldn't work. I think we were hoping for a more sort of formalized process that I know that the Roy Ball Center has put together, but it didn't really go that way, because there were just, every single one of them had so many challenges associated with them. We just couldn't get to that place. But I'll show you what happened, and I'm actually quite happy that it happened. So just first of all, to tell you some of my impressions, everyone agrees that oral health is important, but everyone also says that it's really difficult to do. Nobody addresses it systematically and just does what they can do. So I've had case managers who've said to me, well, I've had people who can't eat the meal, and so I've said, well, what do you have them do? And they say, I bought them a blender on my own penny and have, taught them to blend the food. Somebody else said, well, I told them to re-cook the food and just boil it till it became really soft. They told me that it's hard to get them blended meals because physicians need to write the order for that, and that it's very difficult to get a physician to agree that somebody needs a blended meal, and especially they don't really think about the mouth too often. So it's usually, if they have swallowing problems, or that's why they get it. Same with Ensure. Is there a blended meal available?
There is in certain communities. Some meal providers cook on site and some cater. Some that have food catering have it. Part of the problem is the Department for the Aging reimburses the providers a set amount, $7 a meal, and that dollar amount does not cover all costs. So the agencies, are not, I mean, these are local community-based organizations to begin with. So the answer is yes and no, and there should be more. The department is working towards trying to get more variety, because we understand that if they're getting the meal and they're not eating it, then there's no point in giving them the meal. So yes and no.
And, it's the same thing with chopped meals. So when I've given out meals, I've always given out like a whole apple.
Right.
But if somebody has dentists, that's impossible. And I've been in homes where, it's like a dorm, actually. There's a little kitchenette at the end of the corridor, but that man, specifically the one in the wheelchair, he lives in a place like
It's like an SRO,
Yeah.
It's one bathroom that they share on the floor and then a communal kitchen.
So he's in a wheelchair, and I doubt that, he would go down there to chop his apple. Also, case managers, they're aware of dental problems, but they don't know where to send people. So if somebody says, I have pain in my mouth or I can't eat this food, there's nowhere to send them, because, like I said, the dentists are not easily accessible. People don't accept Medicaid. There's no directory, there's no listing, there's nothing formalized.
But the case managers are working for
The Department for the Aging. So they're the ones who are assessing clients to see what benefits they're entitled to. Out of their 20,000 case management clients, 17,000 get Meals on Wheels. So those others get things like home care or other services. They just don't get Meals on Wheels.
That's an ongoing relationship.
It is an ongoing relationship. They go in initially to assess them. They have to go in every 6 months to reassess them. In between that time, they're supposed to call them a couple of times. It's not a lot of time, not a lot of face time, not a lot of individual attention for a lot of these clients. So some clients, as we were talking before, the more active ones, are sort of left on their own. So the ones who have a lot of issues are the ones that are focused on, because case managers have caseloads anywhere from 80 to 100, which is huge. Children's services are mandated. I think caseworkers are not allowed more than 25 or 27 cases. There's no limit for older people. Our society is an ageist society, but some of the problems I don't think that government understands, that there is just as many issues or problems as there are for younger people as there are for older people. They're just different.
So these case managers would also have adult protective responsibilities? Oh, wow.
It's a lot. So they might have a caseload, let's say, of 80 or 85, but 20 of them are involved with elder abuse, or, they can't pay their rent, they're about to be kicked out, and then the rest are okay, but just focusing on those can be a tremendous amount of time and energy. So in terms of what their interaction is with the clients, for some of them it's really not a lot. So the meal deliverers, those are the ones who see the clients every day. They can see what's going on. They can tell if the client isn't eating. They'll see a stack of apples or something in their kitchen, and they'll know that they're not eating. They have to report back, but again, what is there, what can be done after that is sometimes, there's nothing to be done. There are a couple of schools of dentistry in the city. They're located in Manhattan, so those who don't live in Manhattan have trouble accessing it because they're not going to get on the train or a subway, and they can't, or a bus, and they can't afford, car service. And even the ones in Manhattan, if they live uptown, they can't go downtown. So it's really...
It's complicated. It's very complicated.
Inaccessible.
And case managers, I think that the case managers, some of them are super committed. To go out and buy a blender for your client, or and some of them are, just really, really work with them. They were telling me stories. Some of them try to help them nutritionally if they've got diabetes. So that was something they were very interested in, because they felt that this would be a new sort of talking point for them to speak with their clients about a new way to manage their disease and have a new entree. But, they told me stories about how the nutritionist came over and advised someone to grow her own vegetables. And, looking at me like, she's in a wheelchair.
In New York City.
So, but I've met all kinds. Some I just felt were just not engaged, and some were so super committed to what they were doing. So eventually, these were the potential interventions we came up with. the first was that we felt we needed to know exactly what was going on, who has teeth, who doesn't have teeth, who can eat, who needs to get to the dentist, just something. DFTA is not collecting these data right now. We also thought that we need to find a way to link meal recipients to dental providers. And then we thought that, wouldn't it be great if we could just give out toothbrushes and toothpaste and denture brushes with the meal, like with a little sticker that says, don't forget to brush after this meal. And that seemed easy enough, but it really isn't, because we don't know who has teeth and who doesn't. And you don't want to give a denture wearer a toothbrush, because if they use the brush to clean their denture, they're going to ruin it, and then they can't get one for 6 years. And so if you're going to be also giving them these things, then you want to be giving them some sort of materials telling them what they need to do and symptoms and, what they should report to their case manager and so on. And then looking for sort of ready canned materials, we found that there was nothing that really targeted this population and spoke to them and or that was appropriate for their needs. Of course, delivery of special textured meals was something that's always there, but it's not easy, as Rachel has explained. Also, I think they have to deliver the meal at a certain temperature, and so if you're going to blend it, it gets cold. And also, if your client needs to get a special meal, the physician has to sign off on it. And so the case managers feel that that's just too much work, to get them to actually do that.
If they have a regular physician that they see.
That's right.
Are a substantial proportion of still being delivered as frozen meals?
No. Very small proportion. You're referring, when Ed did the study with us, there was a huge consolidation, a huge issue going on in the city. The commissioner at that time thought he'd, cost efficiency, save money by providing only frozen meals to clients, which they do in most parts of the United States, because out in Montana, when you're delivering, you're driving for 40 minutes just to one client. So they chose the Bronx for political reasons and because it's a small borough, and they mandated that 70% of the clients would get hot meals delivered daily, 30% would get frozen 2 days a week, 4 and 3 meals, and the ones who got the frozen meals would have been assessed by their case managers, able to handle it. They have the cooking facilities to do it, a microwave or a stove, and they are cognitively and physically able to do it. There was a big backlash, so when the rest of the city went frozen or hot, it was left up to the case managers to really decide who was going to do it, and the percentage is tiny. It's maybe 2%. I don't even think it's that much for the rest of the city. So, again, there are clients who could use this, those who get chemo, those who get dialysis a few times a week. They're not home to get their meal. And if they're not home, then they shouldn't be getting meals, but with this option of the frozen meals, they can do that. But yes, it's a good portion right now.
Okay.
Oh, and the other piece of the frozen meal, the other issue was that it wouldn't be the daily contact with the deliverer, which is such a huge piece. New York City, thousands of people can live in one building, but you can never see your neighbors. People live very anonymously behind closed doors, especially with this population. They don't get out. So not having that daily contact was a big issue, and so that's really been important to maintain for most of these clients.
Yeah, I had some delivery people telling me that they were the ones who found the client dead in the apartment and sort of made let everyone know and so on. So these are really isolated people. So what happened?
They're not supposed to have keys. Some have means, but it's really knocking on the door, and either somebody says, I can't get up on the other side, or they don't answer. And then the protocol is, if they don't answer, they have to call back to their agency and say, Mrs. Smith didn't answer. And then the case manager will say, well, you go to the next client, and we'll follow up with Mrs. Smith. Or if, this meal deliverer saw that person yesterday, knew, there was something wrong, if there's maybe a doorman or a super, they'll open. I mean, that's, it's a small community, and the deliverers are well known in the building. They may know a neighbor or the super. So, yeah.
So, what happened? One of our CAB members is from DIFTA, and she started to become interested. I took some of the data from the other study, through Triple, and she became very interested, invited us to DIFTA to talk about our results, and DIFTA became a key player with us. So the partnership has now expanded to include DIFTA, so much so that their assistant commissioner has taken a leadership role, and we get invited to meetings all the way in the bottom of Manhattan every month. I think, for political reasons and many others, he's just trying to move this agenda forward and really wants to make something happen very quickly.
There's a mayor's race, if anybody knows, in New York City soon, so there's going to be a new administration. So they want things to move quickly, too, to make sure we get this in.
They get it done before everything changes. He is interested in sustainable programs with reach. That's what he says at every meeting. Make this sustainable, make it have reach. We've put in some collaborative proposals with them, and I'll talk to you about that later. But we're also exchanging students. Some Columbia students have been selected to be public service corps interns for the summer, and they're going to work with different to develop outreach materials, that I showed you as one of our wants from the possible interventions that also the case managers had asked for. So we've had some policy happen. If you remember, our very first potential intervention was to have some sort of documentation of oral health or oral health needs. When we started this work with DIFTA, they were just changing their assessment tool. It's called STAR. And so we were there at a very, opportune time. We told them that we really need to have some oral health-related items in this assessment tool, and we asked for 10. We got 4. But at least now we have it integrated into their assessment tool, and it'll be there until they decide to change it again, I suppose. It will go live this September, and they promised that within 6 months they will have evaluated all 20,000, and so we'll have a good idea of, somewhat what's going on. We keep going back to the case manager and saying, okay, so the case manager is going to ask if people have teeth. These are questions that they're going to ask. These are the first two questions are just about, do they have teeth, do they have dentures, do they have difficulty eating, and why? And then, do they have difficulty cleaning their teeth, and why? And then also, when was the last time they went to a dentist or a hygienist? So I keep saying to them, we've got to have the case manager do more than just ask these questions, and they keep reminding me that the case manager can only assess and make linkages. You cannot have them do very much more than that. So really now finding a way to build a directory where they can refer people and get them to the dentist is sort of paramount importance. You can't ask them to ask people if they have a problem and then not have them do anything with it. Yes?
So I imagine that the reason that they kind of put those limits on the role of the case manager is so they don't get
Overwhelmed.
quantified. I mean, they're already quantitative.
That's right. Another thing.
When a case, maybe through the assessment process, that there's a functional relationship between the oral problems they're having and other problems like nutrition or, just not being able to eat and have mental health effects. So the case manager might already be dealing with those other issues, spending time dealing with it.
Right.
So this is an upstream problem. Is there a potential to ever fold that into their role?
I think that we, I think the commissioner would like to just go ahead and do this, but we have to be, we have to provide evidence that that's what's happening. So I think when they collect this first round of data, we'll at least be able to see, do you have teeth? Can you eat? Are you able to get to the dentist? We'll have those 3 pieces of information, and I'm hoping that we can use those data then to maybe get some more funding to make those connections. And it's interesting that you brought that up, because I said to the assistant commissioner, well, you give out meals as a benefit, so why can't you give out toothbrushes as a benefit? And, I saw his eyes light up a little bit, and then he said, so, how much would it cost, and so on, and we got a company that said that they would give us the brushes at cost, which is 25 cents. And he said, well, we can't afford it for everybody, but if you can find out, who has the most problems, and if it's income-based, maybe we can do some sort of income-based benefit. So, it's the same old thing. You have to provide the data and provide the evidence before they'll move on it, but at least they're interested, and that, they're thinking about it and considering things.
You're going to get to this eventually, but how is the family involved in all of this? I mean, how do you involve the family? Is there a family to involve?
I think in some cases there are families to involve, and in some cases there just aren't. And so I think that's not been sort of on the top of our agenda, just because there's so much variation, and we didn't want to start there. But, perhaps eventually that would be something. The case managers have spoken about it, that, when you build the outreach materials, you should have things that can speak to the family as well, or other caregivers, because they make decisions in many cases for these people.
And then, you talk about getting them to dental care. Who's going to do that?
Well, again, New York City, people have spread out across the country. There's plenty of children who live in California or other places that they feel that they're on top of the care of their parents, but maybe dental care, oral health is not, they see their physician, they have their nurse come in, they have their medication management, but dental care is not part of it. And the physicians are not looking at that as part of the reason maybe why they're having issues eating. So again, with the educational materials, in terms of taking them, that's another question. If it's not going to be a family member, it's going to be a home health aide, an escort an okay escort in some cases, a volunteer in other cases. We're trying to build that into the program as well, trying to figure out how we can maybe even bring someone into the home to do this dental care. So yeah, it's all going to, come at the same time to make sure that we have the right materials for those without caregivers, the ones with the caregivers, and then the ones who maybe the caregivers are there but not really enough support for them. It's such a mix.
So I spoke about this. DIFTA is now beginning to consider having oral care daily aids being given out as a benefit based on income. We secured a donation from Colgate, 600 toothbrushes and toothpaste once a quarter. And, City Meals is going to head that effort in trying to get them delivered with the meals. But, of course, the first challenge is knowing who has teeth and who doesn't have teeth. And we're, just looking at this as sort of a pilot of whether you can actually deliver them or not. Of course, the other issue is when they got the brush, did they use it? And did it actually have any effect on their oral health? So that's another grant. And the outreach materials that would go with it don't exist. We just applied to the New York State Health Foundation to address case manager training and also build a toolkit for them. So the toolkit would include, directories and places where you can refer people to. We'd want to include whose office is wheelchair accessible, who provides services on a sliding scale, who accepts Medicaid, and it would have to be done by borough, and who speaks Spanish and who doesn't, and all these things, as well as outreach materials, both for case managers so that they have talking points, and for materials that they can leave in the home with the meal recipient. We wrote the letter of intent a couple of weeks ago. We got a favorable response, and the full proposal will be submitted on June 7th. The other big thing that happened was that DIFTA, without really my knowledge, applied to New York State for Article 6 funding, which happens to be discretionary funding that the state has and they specifically asked for this funding to build outreach materials. They don't know yet if they have got it, but we were able to place a dental student there for the summer, and the role is going to be to help develop the toolkit, and another student will be placed at City Meals who will help develop it. We've done some dissemination. We've put in 2 abstracts to APHA and 1 to GSA, and we're also writing a manuscript right now for the Journal of the American Public Health Association. We did write a proposal to the Samuels Foundation, but it was turned down. And we're talking with a board member at City Meals to sort of help us find some other funding, perhaps through Robert Wood Johnson. And there's another dental foundation called DentaQuest. That's another one in consideration. And then finally, I think this project has really resulted in improved visibility for oral health at DIFTA. You know, now it's like something that they really want to do. I'm not sure. I think some of it was because of the data that we presented. When we said 40% of your people aren't eating the food that you're giving them, that was like, okay, now we're wasting a ton of money. But also the Department of Health has started a subway initiative on oral health for children. So I don't know if there's some, you know, they're doing the math, we should do the math too. But I think there's been some visibility for City Meals. I know their board is now very interested in the mouth. And of course for Columbia, you know, we've got the donation from Colgate. That's a really big deal. So Columbia is sort of gearing up to do a big PR piece on, you know, we're the dental school in New York that's looking in people's mouths in the home. So I'm going to come back to this in just a minute. Just to tell you what we're thinking is going to happen next. We're, you know, hoping that we're going to strengthen this partnership. We're looking for additional funding and also for corporate sponsorship. We have one toothbrush company that has agreed to sell us the toothbrushes and toothpaste at cost, which I think is doable. We're also talking about considering a home-based model of dental care delivery. I'm not exactly sure what it would look like. We started with thinking about a dental hygienist, and New York State was going to change practice regulations, but decided now not to because whatever bill it was attached to didn't pass. So a hygienist, I don't know what it was. A hygienist cannot go into a home unsupervised, which means then you have to have a dentist, and that just, you know, might as well just send the dentist by themselves. Dental therapists are being used in Minnesota and Alaska. They haven't come to New York yet, but, you know, it's something to consider. And the ADA has a new dental health provider called Community Dental Healthcare Coordinator, which I think is our best bet because the Community Dental Healthcare Coordinator doesn't need to be supervised and can go in, can assess the mouth, can provide some preventive interventions, and then can also, you know, make the referrals and the linkages. So I think that would be the best bet. DIFTA is really on board with this. 20% of their clients have Medicaid, so they think that they can make the numbers work in terms of, you know, hiring someone and just making it sustainable and using a sliding scale for everybody else. We just have to get New York State to, you know, think about their practice act and let these people come in. They have to be trained. I think it's a 2-year training, and there's some politics around it because the ADA wants the Community Dental Healthcare Coordinator and the public health people want dental therapists, and, you know. But I think for this population, the ADA's worker actually would be a much better bet. Because in the home, there's only so much you can do. You can do prevention, you can do some very basic, you know, restoration, but if somebody needs a whole denture or needs a bridge, you really have to get them to the dentist. DIFTA is also now beginning to talk to us about, you know, can we do this with people who receive congregate meals? And so our first focus is with Meals on Wheels. That's where we started. We feel that they're the most vulnerable people. They're at home. They're hard to reach. But eventually, hopefully, we can, reach others as well. And, I keep trying to tie the math to the body and, hoping that we can get physicians involved and other healthcare workers, because I think that this problem is too difficult to link people to dental providers on a, it's mostly episodic care that they're going to get. It's too complicated in terms of our public financing. So I just want to go back a little bit and talk to you about, my reflections about the money that we were given to do this work. I think if, Dr. Reid said that I've worked with communities for a long time, and I have since 9/11, so that was 2001. But I've never had the liberty to do it in this way. Usually it's been you get a grant and you have a community partner and sort of you kind of tell them what to do and they do it, and if you have a good relationship, it happens, and sometimes they'll say no. But the money through this through Bronfenbrenner really gave me sort of the time and the money to build the relationships, to make the relationships, and to go slowly, to really find out what they want and what they can do, and how we can make it happen so that it will be sustainable. And I think, in the past, whenever I've done this kind of work, it's been with one agency or two agencies. It's never really expanded citywide. But now DFTA's on board, and, STAR is going to happen. It's going to be for everybody in the city. They're talking about the toothbrushes. It's not going to be just, City Meals clients. It's not going to be the Upper Manhattan clients. It's going to be everybody in the city. So, for me, this is just very, very exciting, and it really has been a small amount of money that I just have felt has been so very useful. The other thing is that I've found that it's very important to have a champion. So at City Meals, Rachel has been the champion, and I don't know very much about Meals on Wheels, but she's just a phone call or an email away. But she's also just there pushing the agenda forward. She knows everyone at DFTA. She knows what the politics are. At DFTA, Michael Bosnick has been the champion. And if these two people weren't there, it would have been so much more difficult for me to sort of say, no, we need to do it, this is important. There are competing priorities. I like the math, I'm a dentist, that's why. But I think you just have to find a hook, you have to frame the issue. With Triple, the issue was pain. I went to Dr. Reid and I said, they have dental disease, they have pain. To City Meals, the issue was eating the food. And DFTA, when we said 40% aren't eating and you're wasting a ton of money, that was the issue. And, eventually we're all hoping to build a healthier nation. So, we're all working in the same space eventually. And then, of course, funding and visibility are very important. And I know this, for me, myself, I'm someone at Columbia, I'm always looking for more money, but the Bronfenbrenner money, some of it went to City Meals, and, we were able to leverage that money for focus groups and transportation and so on. And now, in moving forward with New York State, the funding will allow City Meals and also DFTA to do things differently. So I don't know if you wanted to say something about your reflections.
Just in terms of City Meals, the ability to take policy to really help create policy is pretty big. We did this wonderful study, and now it's almost 10 years old. We have to do another study, and that really allowed us to see who our recipients are. We deliver the meals, but what's their income level? Where are they from? What's their education level? And are they eating? And why aren't they eating? And what time do they eat? And do they eat half the meal, and is it because they don't have enough food? So this takes us, now we have a focus, and obviously our mission is nutrition. That's a huge part of our mission. So if we can really get the right meals for them and figure out why they're not eating and then help them to do it, it's incredible, and we can't do that without DFTA. So having DFTA on board is huge. I mean, we're finally going to have the data that we've never had all these years. We've never had one data system, and now they're going to have it. So it's going to be pretty big. And if New York, I think if it happens in the city, you know, everyone wants to follow the city, so it might go nationwide. Be very helpful.
So, I know we only have 5 minutes, and these are just some questions that I had for you. You know, are there partners that we haven't considered? These are really difficult times economically, so we're building momentum, but, you know, I'm just afraid that it's just sort of all going to die. And also, you know, is there anything that we could have done differently?
Questions? Thoughts?
So in my free time, I'm a bit of a documentary junkie, and this has me thinking of something I saw years ago on home visiting dentists for what they called Mountain Dew mouth in children in Appalachia. I just wonder if you're familiar with that or how that was funded.
Well, you know, the thing is that Medicaid pays for children's dental health. They don't pay for adult, so that's why it's complicated. And you know, children's oral health is in a completely different space now because Medicaid pays around the country. It's generalizable, and so you know, big funders want to fund it because then you can transfer it into other settings. The other thing too is that pediatricians now are actually being paid to do children's oral health. So pediatricians can do fluoride varnishes and so on, because some of those issues still exist, even though Medicaid will pay for children's oral health. Just getting the children there and so on regularly is difficult. We just don't have the same sort of commitment.
It's a little anecdotal, but I feel like you never hear really bad reputations of doctors. If you ask around about dentists, some dentists are like, and I think it's the juncture of like paying out of pocket and pain, and especially in cities, I feel like there are some shady dentists operating.
Oh, there are.
And I'm wondering if like, for this population, do you think that's a barrier, just fear of like, I'm going to sleep and I'm
Well, it's also, there was a huge epidemic in Florida, maybe a decade ago, where dentists were taking out all the teeth, because, you know, they would convince these older people, and then, because they would get paid for it, and there was no reason to take it out. So those are the kinds of issues that I think older adults are also afraid of. So there's the stigma and the fear of going. And doctors are also placed on a different, I think, level still, especially for that population. I mean, their doctor, that's their doctor. That's who they go to. I mean, a dentist is not really considered in that.
Right.
But yes, I think you're right. I think, you know,
Well, I want to
policing
follow up on
Medicaid
that.
too.
What about the quality? Because this may be part of a toolkit. So you were referring somebody to a shyster, in essence, ultimately.
Right. So we have to really
quality control.
vet them. Yeah.
Right.
And you know, for a lot of older adults, if they don't have teeth, they think they don't need to go to the dentist. So that's one big thing. You know, I don't have teeth, I don't need to go. But there's a bunch of stuff going on under that denture, or it doesn't fit, you can't talk. The other thing, too, is that I think a lot of people just didn't grow up with dental care. You know, it's not, the case manager said to me, this isn't their priority.
Right.
If they have extra money, they'd much rather go to the optometrist,
Podiatrist.
or to have their hair done, or whatever, because, you know, that word kept coming up. It's not a priority. And so they kept saying to me, you know, you need to make some educational material so that we can help them prioritize. And when I talked about diabetes and gum disease, they said, oh, this is perfect, because, you know, they understand that their diabetes is related to the gum disease. Maybe they'll go. I think some of that, you know, and especially among poorer communities, in a lot of the work that I've done with poorer communities, this is just not, I'd never been to the dentist. I didn't think I could go. A lot of the people, even if they have Medicaid, about 80% of those who have Medicaid don't realize that they have dental benefits.
Who's the most appropriate person to deliver the intervention? Is it the person delivering the meal or the case manager?
Well, I think in an ideal world it would be the one delivering the meal, but they are not appropriate for that. So it would have to be the case manager.
other outcomes are you looking at besides the amount of the food that they're eating? And how do you control for all of the other things that, affect the amount of food that they'll eat?
And, that's a really good question. We're not even looking at that. We're just simply asking them, can you eat the food that you're eating? And if not, is it because of problems with your mouth or teeth or dentures? It's a very small study with very little money.
How did you get to the point where you knew that 40% of the food wasn't being eaten?
That's a study through Triple, funded by the NIA, in which we're phone calling.
A study of some 10 years ago.
Yeah, 2005, we did a study, took a percentage of our clients, of the Meals on Wheels clients, and asked them a whole bunch of questions, like if they got their meal, what time were they eating it? Did they put it in the refrigerator? Did they only eat half? Why? How much were they eating? What kinds didn't they eat? So we asked them a lot about that to understand what they were doing with the meal. What were they using it for? And many of them who said they were only eating half, some said they were only eating it because they weren't hungry, and others said they were saving it for dinner.
There are so many things that affect how much of the food they eat.
Absolutely.
I'm just wondering if there isn't another outcome measure that you could consider or look at.
I'd like to second that, because I think as you build this program forward, both the nature of the intervention, this is so great proof of concept. And for those of you who don't know, the New York City Department for the Aging is bigger than a lot of state departments for the aging in some states, so it's a very large and Byzantine organization that really is hard to crack. So that's an amazing outcome to get them and to actually influence policy. I have the same question about outcomes and about interventions, but the giving of the toothbrush and toothpaste would seem to have symbolic value and might make someone more alert, but it does seem like something relatively inexpensive to purchase themselves. And without, what's the evidence? Well, I guess I have a set of interlocking questions, because it seems kind of almost an ecological model, that you need to train the people themselves who are receiving the meals, the people who deliver them, their case managers. You also have to improve access somehow to potentially costly services, and you want some individual behavior change.
That's right.
But in some ways, the least persuasive seems to be giving them the equipment, because, first of all, they probably reached a stage of advanced problems where I don't know how much even is daily care at that point going to...
It will, because you can arrest it. That's the thing. So before it gets to the point where it's going to become an abscess, if you're putting fluoride in the mouth through toothpaste, you're going to be able to arrest it. You're right in that, if it's there, you eventually have to clean it up and you have to get them to the dentist. But you can arrest the disease process, and you can also mitigate morbidity.
But I think in terms of outcomes, you have some relatively clear ones compared to what a lot of us, work on.
But you're right in that...
Day-to-day dental hygiene, consume more food, have fewer dental problems.
But you're right in that if we do give a toothbrush, how do you know that they used it? Or how do you know their nephew didn't come and take it?
Tiny sensor.
So it has to be a much larger study, and I think, we have to be going in and doing oral exams. We have to be in the home. We have to look at exactly how much dental disease there is and whether this will even clear it up. And you're right, too. They may not be eating for a bunch of other reasons as well.
But in terms of the meal, we want to make sure that they have the right type if they need some sort of whatever it is, and that they're going to eat whatever they have, and if they have other issues, that we need to address that. Because if they're just getting the Meals on Wheels just to have somebody come visit them, then maybe they need another kind of program. But yes, it's definitely a priority for us.
Yeah, it's like a big multi-arm study with these different kinds of...
It is.
Well, we keep figuring out new...
Yeah, and we're just trying to tackle it piece by piece. And so we're hoping that, if we can get sort of an allied dental professional in the house, that would be the best case scenario, because then, unlike a caseworker who can only really give out materials, they can do education, they can look in the mouth, they can really do some targeted interventions and get people where they need to go. But that really depends on big policy. But, if we can get DFTA to help us move policy through the state.
We're still going to need an outcome picture, or actually we should have a group of them that basically show that, what you're doing leads to better oral health, leads to better nutrition, leads to better whatever, quality of life, or, that you really need to put that chain of evidence together.
Absolutely.
Well, part of it is also, we look at Meals on Wheels prevents or puts off the institutionalization. It allows people to live in their homes. And we've proven that with, and it saves the state a lot of money. If we can add this to it to say that because of this, they're able to eat the meal, so then therefore, so yes, I think we need to somehow put that together, because if the state also looks at that, it's a lot cheaper to keep somebody in their own home than institutionalize them, obviously. So that would be very helpful.
So you in proposals, you listed those more distal outcomes. I agree.
Yeah.
In order to have credibility, you're going to have to show
You
that.
could even measure the amount of meal consumed if they would throw them away in a
Or
particular...
albumin level. I mean, there's
some, yeah. One very
thinking
easy
about
one would be
weight
to actually
right.
just look in the mouth and see how much dental caries or gum disease there is. But, that's a costly and big study.
Well, I know we have come to the end of our time. Does anybody else have a question? Can I also mention, like, telehealth? I mean, could you have a paraprofessional in there who's using cameras that broadcast to you in your office?
I suggested this to the dental school, and they're just not used to it. You know what I mean? They want people in their chairs at the dental school. They tell me that it'll be too expensive and unwieldy. I think it would be, just even because of the relationship between diabetes and gum disease. I mean, heart disease, stroke, and gum disease, those are really sort of out there in ether, and people like to make those connections. But diabetes and gum disease is definitely a relationship, and it's documented. And I think, if you can even have a nurse sort of looking in people's mouth and sending out little telepictures, this is how much inflammation there is, and
Visiting nurses.
yeah, absolutely. That's with Isabella Home Care in northern Manhattan, we trained the nurses and actually did find that the prevalence of oral disease went down after 2 years. So we went in, we did baseline, and then trained the nurses and came back after 2 years. But that's a very defined agency, and they have long-term Medicaid patients, which means that they can have a home health aide every day for 20 years, but most places you can't do that.
Unless anyone's wondering about why folks from Columbia are here, our Triple has a joint partnership with Cornell Columbia Translation Institute for Pain. We include folks from Columbia.
Thank you.
Thank you.